Pityriasis Rubra Pilaris, PRP, unveiling the layers of a mysterious skin disorder. Welcome, everyone. Today, we're diving into the intriguing world of dermatology to explore Pityriasis Rubra Pilaris, PRP, a rare and captivating skin condition that continues to challenge and fascinate clinicians and researchers alike. Buckle up as we journey through its history, epidemiology, pathogenesis, clinical features, classification, pathology, differential diagnosis, and treatment options. History. Our story begins in 1835, when Claudius Terrell first identified PRP as a variant of psoriasis. This was just the beginning of its fascinating evolution. Dermatology later named it Pityriasis Pilaris, highlighting the follicular nature of the disease. Besnier enriched our understanding by coining the term Pityriasis Rubra Pilaris in a detailed, illustrated article, emphasizing the redness and scaling characteristic of the condition. Epidemiology. PRP is an equal opportunity condition. Gender prevalence. It affects males and females equally. Age peaks. There are two prominent peaks: early childhood, first and second decades of life, later adulthood, the sixth decade. Ethnic variations. Subtle differences suggest that genetics and environment might play roles. Inheritance patterns, mostly acquired. The majority of cases occur sporadically. Familial forms, primarily autosomal dominant, less commonly autosomal. Recessive genetic mutations. Mutations in the CARD14 gene are pivotal in familial forms. Disease resolution, generally self-limiting, resolving within 3 to 5 years, except in non-classic forms and those with genetic mutations. Pathogenesis. What sets PRP into motion? The exact cause remains elusive, but several factors are in play: triggers, infections, ultraviolet, UV, light exposure, minor skin injuries, autoimmune factors, particularly in patients with thyroid diseases, suggesting an aberrant immune response. Paraneoplastic associations. PRP can be a harbinger of internal cancers like renal cell carcinoma, lung cancer, and hepatocellular carcinoma. Drug-induced cases, rarely. Medications like infliximab, tyrosine kinase inhibitors, antivirals, or vaccines can trigger PRP. Inherited forms. CARD14 mutations disrupt normal skin cell signaling, leading to PRP's characteristic features. Clinical features. PRP paints a vivid picture on the skin. Skin lesions. Follicular hyperkeratosis leads to rough, scaly papules resembling a nutmeg grater. Red-orange plaques. Large plaques with islands of sparing where the skin remains unaffected. Erythroderma. Potential progression to widespread redness and scaling. Palms and soles. Keratoderma. Thickened, waxy, orange-red skin, making daily activities uncomfortable. Scalp involvement. Redness with fine scaling, often mistaken for seborrheic dermatitis. Nail changes, thickening and discoloration. Yellow-brown nails with debris underneath. Mucous membranes. Rare involvement. May resemble oral lichen planus. Symptoms. Itching and burning, reported in about 20% of cases, impacting quality of life. Disease progression. Onset and spread, often starts on the head and neck, spreading downward. Rapid progression may quickly advance to erythroderma over weeks. Associated conditions. Viral skin infections, increased risk of eczema herpeticum, Kaposi varicella eruption. Photoaggravated forms. Symptoms may worsen with sunlight. Resolving patterns may mimic erythema gyratum repens. Classification. PRP comes in 6 flavors, each with unique characteristics. Type 1, classic adult. Most common form, rapid onset and widespread involvement, typically resolves within 3 years. Type 2, atypical adult. Features: coarse scaling on palms and soles, ichthyosis-like scaling on legs, possible hair loss, alopecia. Chronic course. Type 3, classic juvenile. Similar to classic adult form, occurs in children and adolescents, usually resolves within 3 years. Type 4, circumscribed juvenile. Most common juvenile form, localized areas, often affects elbows and knees. Type 5, atypical juvenile, often due to CARD14 mutations. Features: chronic course with ichthyosis-like scaling. Overlapping signs of psoriasis. CAPE. early onset with facial and extremity involvement. Type 6, HIV-associated, linked to HIV infection, treatment challenges, may not respond to standard treatments. Can improve with antiretroviral therapy. Additional features: severe acne-like lesions and hidradenitis suppurativa. Pathology: the microscope reveals PRP's signature, skin biopsy findings, checkerboard pattern, alternating orthokeratosis and parakeratosis, creating a distinctive look, dilated hair follicles, filled with keratin plugs. Parakeratosis around follicles, thickened granular layer, shortened reedy ridges, sparse inflammatory cells in dermis, differentiation from psoriasis, acantholysis, loss of cell connections, not typical in psoriasis. No neutrophil migration, absence of Monroe. Microabscesses. Differential diagnosis: distinguishing PRP from other conditions is crucial. Psoriasis lacks islands of sparing, different nail changes, seborrheic dermatitis. PRP may mimic this on the scalp. Suspect PRP if resistant to treatment. Dermatomyositis and cutaneous T-cell lymphoma can have similar skin findings. Kawasaki disease, acute PRP in children might be mistaken for this. Erythrokeratodermia variabilis and ichthyosis with confetti, overlapping features but differ genetically. Pityriasis pilaris and lichen spinulosis, also present with follicular papules but are more localized. Treatment: managing PRP is a balancing act. Topical therapies: high-potency corticosteroids, tame inflammation, coal tar preparations and vitamin D analogs, calcipotriene combat scaling, keratolytics, urea, salicylic acid soften thickened skin, topical retinoids, tazarotene, tretinoin normalize skin cell growth, systemic retinoids, first-line treatment, isotretinoin and acitretin, dosage, isotretinoin, 0.5 to 1 mg/kg/day, acitretin, 0.5 mg per kilogram per day, response time, improvement in 3 to 6 months, efficacy, over 40% of patients show excellent response. Methotrexate, second-line treatment, for those who don't respond to retinoids, dosage, 5 to 25 mg weekly, efficacy, high response rate, complete clearance in approximately 40% of cases, monitoring. Regular checks for liver toxicity and bone marrow suppression, combination therapy, retinoids and methotrexate, used in severe cases, caution, increased risk of liver toxicity, requires close monitoring. Biologic agents, TNF inhibitors, etanercept, infliximab, adalimumab, interleukin inhibitors. Secukinumab, IL-17 inhibitor, ustekinumab, IL-12/23 inhibitor. Usage: for refractory cases, responses vary. Other treatments: immunosuppressants, azathioprine, cyclosporin, prednisone, apremilast, an oral phosphodiesterase 4 inhibitor, intravenous immunoglobulin, IVIG in select cases, phototherapy, types, narrowband UVB, UVA1, or PUVA therapy, combination, often with oral retinoids. Considerations: risk of exacerbation, monitor skin response closely. Pediatric considerations, gentler approaches. Due to potential side effects and likelihood of spontaneous remission, monitoring growth and development, essential when using systemic treatments in children. Conclusion: PRP is a complex tapestry woven with intriguing clinical features, challenging differential diagnoses, and varied treatment responses. Understanding its nuances not only enriches our medical knowledge but also enhances patient care. Thank you for joining me on this exploration of Pityriasis Rubra Pilaris. Your curiosity and dedication to learning are the keys to unlocking the mysteries of rare conditions like PRP. Let's continue to expand our horizons and improve patient outcomes together.